Hi there, it's Gabrielle Nicolay from SpeechKids, where we teach little kids to talk and help parents understand their little kids. And today I'm so excited to be talking to Dr. Jonelle Anamelechi of Children's Choice Dentistry. You are tell the good folks who you are and what you do.
Yeah, hi everyone. As said, I'm Jonelle Anamelechi. I am a board certified pediatric dentist. I have a master's in public health and maternal and child health, which is why I absolutely am excited about this conversation. And I'm the owner of Children's Choice Pediatric Dentistry and Orthodontics. We're in Northeast DC and Newtown, Maryland. And I'm attending faculty of 8 budding pediatric dentists at Children's National Hospital. So it tends to be full at times because I'm a mama too. And but I absolutely love the interactions I'm able to have because of those relationships.
Well, and we connected not too long ago, but have definitely figured out that we understand each other very well. And so we were just talking before I hit record about relationship, which is a word that gets me very, very excited. And so talk about, when we think about dentists and speech therapists, it's not an automatic pairing for many people.
No.
And it should be. But so let's talk about why that is. How come it's not automatic and why should it be, and talk.
Well, I find it's quite interesting, right? Because I feel like I used to, I won't say now in our practice, but I used to feel like we were stuck to the teeth, or parents expected us to stick to the teeth. And so, if the teeth are healthy and there are no cavities, then all right, we check it off and we move on. And as we continue to move forward, we're like, hey, we are so much more than that. And we get to see our kids every 6 months from the age of 1. So think about all those bursts and changes and growth experiences and life experiences that are happening. We get to see that. And so once we started, really telling our families, hey, we are going to ask you a slew of questions. We're going to ask about sleep. We're going to ask about swallowing. We're going to ask what kind of foods they eat and how they feel when they eat them. And, and sometimes parents go, well, that's not, there's something medically going on, but that doesn't matter at the dentist. And we're like, absolutely it does. And so by the ability to then say, I see something, I hear something, and then I have someone for you, parents are like, oh, wow, this is cool. So we get out of the just baby teeth phase, which I hate that. I don't want to be just in the baby tooth game because we see ourselves as so much more. And so that's where those relationships matter. That's why I was so giddy when I met you, because I was like, oh my gosh, my soul sister, where have you been?
Yeah, I felt the same way.
Love you all.
Yeah, absolutely. No, I know. It was really we were like, oh my God, this is so much fun. But even as you're talking, I'm having, I'm nodding my head because when I take my kids, I have an 18-year-old and a 15-year-old. I took them to the dentist when they were 3, not 1. But
well, it wasn't then. It wasn't recommended then.
Interesting. Okay, so that's changed too, which I was completely unaware of. And yeah, it was like if the dentist had asked me what kind of food they're eating, I would have said, what business is it of yours? And yet, what is it that we use when we eat but our teeth and our jaws and our tongues? And so then once you get talking about tongues, that's when speech therapists can get a little excited too. And so but it is really interesting how, we're all talking about mouths, and yet we're not talking to each other.
We're not talking to each other. Exactly.
Yeah. And we should be. The other thing I thought about as you were talking is you get to see the kids every 6 months, which is different from the pediatrician because that's once a year unless they get sick. And you have them for a much longer period of time during that 6-month visit than any pediatrician does. And so that's kind of interesting too, just in terms of a developmental screener time, because they're sitting in your chair for what, 30, 45 minutes.
Yep, you're absolutely right. And those are the opportunities now we take to go back sometimes to our pediatricians and say, hey, we noticed this, and this. What do you think? Did you see that in your visit? Because sometimes they may not. I know the checklist that our pediatricians have. And so now we feel like we're more in a partnership where, there are some things that we see and we're like, oh, I don't know. That just doesn't, that doesn't seem like it should be, or we're not on the developmental level that we should be. Let me check in with the pediatrician and see if they recognize this, or have the parent, hey, call up and see if, this was recognized at the last visit. And we've connected a lot of families, and the benefit of early intervention. And so, why not?
Yeah. And it's so interesting that, again, and we don't necessarily think of it, but we do have these touch points, right? In the community, we have these community partners. And when those community partners can be really in a partnership, and looking out for the best interest of the child, and be having multiple touch opportunities for parents who maybe they were worried before. And you're saying something like, I'm seeing this, I'm not really sure, go talk to so-and-so. And particularly, and I love what you said before, particularly if you can actually like provide an action item, like call this person, because, giving a like, maybe PT, maybe speech without an actual name, I don't think is very helpful, actually.
No, it's not.
We're not going to act. It's going to be too overwhelming. We're going to go on Google and like type speech therapy and get 100 million people. And so this again, this notion of like, here's an opportunity, here's a low stakes opportunity to sort of ask the question. There will be people, and I'm sure you've had this happen, not probably who are watching this, but people who say, well, are you just like identifying all the kids who come into your practice as having something disordered or something wrong with them? Do you have this?
I faced that question yesterday, actually. And, what I tell my families when we talk about it is, the more you know, the more you grow. And so it may be that we're saying, oh my gosh, look at this. But it's because we've made those connections. And so last week, I was giving a lecture to my residents, and they're getting ready to graduate. And they hadn't learned anything about speech, swallowing, nothing. And again, I didn't learn it in residency. I took some courses. I need to see the process. So to start digging to say, okay, well, what's that connection? Where does that connect? And where does the breastfeeding connect in the future? And what? So I started asking these questions, and then I find my resource, and I'm like, oh, I didn't know that. I need to know that. Like, how could I not know that? And so when you open your mind up, you see it.
Yeah.
And it becomes so much more obvious of what's happening. And so when we talk about those, incidences of, increased tongue ties and, the diagnosis of them and things of that sort, it's not baddish. It's just that we have a lot more information now to help. Right. And I appreciate that. Not everyone has to be treated, but at least right?
Yeah, that's super interesting. And I always talk to my families about this clinical line, right? What side of the clinical line are you on? Are you on the side where like you need intervention, and in which case we're going to do that? Are you riding the fence? I have many families where I'll say, send me a video in 6 months, or send me a video in 2 weeks, right? Because they ride the fence and it's not clear to me. And as much as I believe in early intervention, I'm not like running around prescribing it for everybody, because that's unnecessary.
Exactly.
And then you've got the kids who, again, like they're on this side of the line. They do fine. They're okay. We can just do a watch and see. It's okay. But
I like giving those options, right? Yes. I like the ability to say, if you're okay, I'm going to see you again in 6 weeks, in 6 months, and every 6 months, I'm going to ask you the same thing, because I want to be there if and when it changes and we need to do something more.
Right. And part of this whole conversation that we're having, and I just want to frame it for the viewers in terms of like the larger child development landscape. This is a very holistic approach. There are very few of us in the field. I feel like there are an increasing number, but there are not as many as you would think, practitioners who think in terms of systems, right? where, and this is very much how I think of a child as being a system comprised of many systems, right? And it's such a weird thing to think at some level, and yet, right? So we've got a 2-year-old who is not speaking, who also is a picky eater, who also is a noisy sleeper and doesn't get good sleep, and therefore has behavior that is off the wall, and who is then making his parents crazy, and having trouble at preschool. And so there's this, organism, this system can be out of whack in a couple of different places, or maybe just in one that's having knock-on effects to their entire life. And we need to start asking those questions. And I love that you ask about sleep. Sleep is huge.
So big. But it's, and I agree. And I feel like in society, it's like, it's math. Like, they're just terrible. It's so undervalued. There you go. That's the word. It's undervalued.
Sleep in particular.
From the beginning. Yes.
Yeah.
From the beginning. And so it's like, oh, they're just a terrible sleeper. Oh, it's just a terrible choose. And this is what's going to be like. And I'm like, oh, no, it doesn't have to be. And that's a big deal. And I think it's freeing to families to know, oh, I can do something about this. Or, there are other options where, they may have thought this is just what it's going to be like.
Let's talk about sleep for a second. Why do you ask about sleep?
Ooh, very varied reasons. Because some of our sleep obstructive disorders are happening from the mouth, from the breathing pattern. So, I'm head and neck, not just teeth. And so when we look in the mouth and we look at the relationship functionally of how it's working during sleep, may it be mouth breathing, may it be how the mouth is shaped, how the teeth are shaped, and that all affects what sleep is going to be like, a good pattern of sleeping. And so there's lots of controversy sometimes about what comes first, right? Does the mouth shape in that way, and then the sleep disorder is happening, or because of the sleep disorder, is the mouth that way? But still, yet it produces a result that is not a healthy sleep pattern. And so those play big roles. We're helping to identify those right off. And I have a personal story to that one. So we help to identify and really exactly and really literally change lives when we are able to identify those patterns. But also sometimes it's not any particular intervention. We talk a lot about sleep hygiene when families are sometimes struggling with sleep or with grinding or things of that sort. We're able to really give some direction. And as you were talking about before, when we look at all these different patterns, it's also very freeing as a practitioner to know I know my limits, recognize my limitations, but also know I have someone else who knows how to pick up from where I am. So I don't have to feel like I have to diagnose everything or cure everything, but at least I can recognize it and know, I'm sending you right to that person, and then we'll work together to make sure we have an outcome that we want to get to.
Yeah, no, and that's certainly true on my end too. I mean, recently in particular, I've had a couple of kids where I was like, I need the dentist to look at this because something's happening here. Things are not moving right. There's like, we've got some things that need a different lens. Sometimes you just need a different lens. And that is, I agree. It's very freeing. It's very, it's just really, it feels like a very supportive kind of place to be where that you can just sort of say, here, take a look at this, please.
And it's a no judgment zone. You can say, I don't know. And that's okay because we'll figure it out together.
That's right.
And I think that's where we win for our families because of the ability to do that and kind of egos aside and all those things aside, just really work for the betterment and the interest of that family and that child.
I will say it's a bit of an education jump for me in particular, and particularly since this is relatively new, things are changing in the landscape. It can be hard because the parents do say, like, why do I need to see a dentist if the speech is an issue? So again, back to how we started this conversation, which is it's not super obvious to everyone.
Yes.
how it is that we collaborate. But let's talk about this for a second. So if we've got a very, let's just, for argument's sake, we've got a very high palate that is being shaped, and then we've got mouth breathing happening. And tell me some of the dental effects from that, and I'm going to tell you some of the speech effects from that. But because that's a situation where we want to do something. Yeah.
So in terms of kind
just
of
in terms of how structure impacts dentition.
Oh, absolutely. So in terms of structure and dentition, it varies, because we could have a smaller mouth, a bigger mouth, a larger jaw, a smaller jaw, and all of that kind of goes into the function of how the mouth works, how feeding happens, how swallowing happens, because it all guides everything behind. So if we had a higher palate, it makes it harder for the tongue to lift and touch the top of the palate. That makes it harder to actually, first time we see those kinds of things is in breastfeeding mechanisms, because in that mechanism, you have to form an actual suction. And if your tongue can't get up there, then you're not forming an effective or efficient suction. And then moving into things like, as we identify that next in terms of complementary foods, and that turns into feeding and swallowing. And so we're going down this line of, what it looks like, and then how do we fix it? And that's where our orthodontics comes in, but we don't really do a whole lot of orthodontics that tolerate. So then that's when our oromyofacial therapist comes in, and we really now start trying to train the mouth and pretty much influence growth. That's really what we're trying to do.
Yep.
And because our kids are so young and malleable, the bones can really respond to the influence that we're trying to make on them at a young age. And so it's really nice to see once we identify it early, because sometimes it takes less time to really get things in the place that it can be, as opposed to if we wait until our bones are hard and formed, and then we have to change a lot more and move a lot more.
Yeah. Yeah. And this is where the early intervention piece, in the same way that when we catch a child who's just learning to speak before they get frustrated, we can deal with the core cause of what's causing the speech delay, and we can override it, and neuroplasticity takes over and all of that. In the same way, a young body is much more plastic. Those cells are growing faster. They're more amenable to change. We can really change a lot. We can change structure and function much more easily and much more quickly the earlier we start. And there are a lot of tools. And so right on your end, the oral facial myologist is working those muscles. So then what happens is, and this is like the next part of the story, which is through nursing, through feeding, through babbling, and this is another area where, you get to ping the parents and say, so quiet baby, noisy baby, what are you hearing? What kind of sounds do they make? What kind of words do they say? Right. So this is, and I've got a whole list for you later, by the way.
I can't wait.
Yeah, I got a whole sheet for you. It's a 1-pager. I managed to get it down to a 1-pager.
Oh my gosh.
But now we need, so that oral mechanism that you're seeing early needs to be the groundwork for speech, right? Because speech happens like in a 2-inch by 3-inch space. We're talking millimeters of movement between certain sounds. We're talking milliseconds of movement between voice on, voice off. I mean, this is like, I always tell this, like speech is like the ultimate fine motor activity, and it's complicated. And it, in typical development, it seems very easy, but it's not. And if we've got a structure, if we have, for example, a high palate that is not enabling the tongue to get up there, and so now we're not latching, and so now we're a picky eater. Now, guess what? If we're a picky eater and we're only eating mashable foods, we've got cheeks that have not done any work. And now we don't say moo, we say muh, right? And then later we say any number of things that don't involve any kind of lip movement or any cheek movement, and then we've got an articulation problem. So all that stuff is happening sort of even before anybody is saying their first word, number one, but it also it's a domino effect as well,
Yes.
right? If we don't have structure and function in place that's real healthy and really good, the other thing is, if you're a mouth breather, you know, and yeah, everything's going to get longer. I mean, there's lots of other effects, but even just from an articulation standpoint, you're going to be drooling. You're not going to be intelligible. Your tongue is not going to be moving around, and you're not going to have that nice closed oral posture so that you can start from a place of efficiency. Anyway, it has, like, again, huge domino effects, but all of this is starting essentially from birth. And, you know, back to our original point, which is you guys see that every 6 months from age 1.
Yeah. And it's wild, because even as you're talking, I'm like, you know, even from birth, even in utero, I mean, because teeth are developing at 6 weeks in utero, right? And then, you know, one of the other day I was reading an article, and they're like, you know, hiccups in utero is one of the initial signs. Were we talking about
No, but I know that babies get hiccups. Yeah.
And I was like, this is blowing my mind. Like, you can you can already look at positioning in the womb, you know, how the chin is moving, you know, all these things are influencing growth and development. And so pinpointing those times and looking at those times is huge, Yeah. I mean, we even asked about length of labor to look at the, you know, head and neck muscles of a baby, to talk about, do they need some craniosacral therapy? Do they need some infant body work along with releasing the tongue? Like, they're important things.
Oh my God. So this is a whole other thing, which I get the stink eye. A fair number of times I will get a stink eye from a parent when I suggest, so I have, there's a couple of kids on my caseload with torticollis, a history of torticollis, that, you know, the torticollis has resolved and they're no longer receiving therapy directly for the torticollis, but they're not speaking yet, and they should be. So now I'm thinking, okay, what's going on from a muscular standpoint? Again, looking at the whole system. Just because one's neck is straight, if one is not speaking and one is not babbling and one doesn't have facility of movement here in the jaw, right? That tells us there's still a restriction somewhere. And, you know, one of the other things I love about sort of this more holistic approach is the willingness to embrace sort of these more alternative, if you want to call them that, modalities, right?
Definitely non-traditional. Yes.
It's non-traditional. And yet, you know, if we talk about acupuncture in particular, it's been around for 5,000 years. Clearly it works, right? Like, and, you know, so people have different feelings. We are always very sensitive about that. The point being, however, you know, yes, let's look at the body and see what we have there, because what we see in the body is what we get in the mouth. And so you really do you don't, to your point, we don't have to know everything, but we have to know what we don't know. And that's, it's both the fun of it and the challenge of it, and why you and I both love what we do.
I know.
We could go on for an hour, but I think we're going to leave it there.
We could. That's a good mic drop. This is a good note to mic drop on.
If people want to find out more about you, where do they do that?
You can look at our website, www.mychildrenschoicedental.com, mychildrenschoicedental.com. We're pretty social, because you can also find us on @Children'sChoiceDental and @Thrive by Children's Choice, which is our center, our specialty center, where we talk a lot more about some of the findings that we make that may be non-traditional findings in a pediatric dental office.
Okay, and that's the Thrive, @Thrive. Do it again.
Thrive by Children's Choice.
@Thrive by Children's Choice. Okay. Thank you so much for being here.
It was a pleasure. Good to talk to you as always.
You too.